Okay. So we have the Minister in the background, so that just saved you all from having to say anything. Okay, so if he's ready, it gives me absolute pleasure to introduce the Honourable Andrew Little, Minister of Health.
Tēnā tātou katoa, kei te reo pōhuri, kei te mihi, kia koutou ngā pau o te whare hauora o Aotearoa kei te mihi. E taura tangata, e taura kaupapa e hono ana i e tātou katoa i tēnei rā, ara ko te Collaborative Aotearoa Symposium te rā Maori ora, kia koutou katoa. Good afternoon, everybody. Thank you for the opportunity for me to speak to you this afternoon. I'm sorry it's from the back of a van at Nelson Airport, and I can't be there with you in person. We had an important announcement with the Prime Minister this morning with the ongoing expansion of the Mana Ake program for primary and intermediate school children, and it was also an opportunity to catch up on some of the important smaller health facilities in this particular region, particularly the Buller Health Centre, which we're doing a rebuild of, and the Murchison Health Centre too, all of which are stunning examples of greater collaboration between different health disciplines, which I'll come to a little more later. So look, great to be here, even if it is in these slightly odd sort of circumstances, at least for me. I know you've been meeting for the day-to-day, so I hope you've enjoyed the ability to do that, kanohi, ki te kanohi. I want to acknowledge the Collaborative Aotearoa Network, especially the important work that you do on the issue of equitable access to healthcare. For many years, Collaborative Aotearoa has championed whānau-centred models of care and community-led approaches. Healthcare Home, which was introduced more than a decade ago, is an example. Programs like Healthcare Home have made a real difference for all involved. You have pioneered new approaches. And the values underpinning those approaches, equity, accessibility, and person and community-centred care, are the very same values our government is applying to drive the changes to our health system. I want to repeat something I've already said at recent GP conferences that I've spoken to. I acknowledge the enormous pressure current circumstances are putting on primary care general practitioners and their practices. The challenges we are facing today have been a long time in the making, and many of them are the same challenges being faced by countries right around the world. It has, after all, been a global pandemic. I know that your kōrero today will have covered some of the things I'm about to say, but I want to assure you that our new health system is designed to put primary and community care at its heart. Overhauling a health system isn't easy, nor can it happen overnight. But if we want a system fit for the future, we have to make bold transformational change, and that's what we're seeking to do. The old system, with its fragmentation, layers of bureaucracy, and unacceptable disparities in infrastructure and resourcing, could not be allowed to continue. We have to do better for patients, and we have to do better for people working in our health system, people who do their best every day to provide the healthcare New Zealanders need and deserve. And we have to do this within the resources we have available to us. And there will always be limits to those resources. That's a fact of life and a fact of government. The COVID-19 pandemic was a catalyst for a significant shift in the way we support health and well-being. We saw the power of harnessing digital technologies, new ways of working, and the value of multi-agency approaches centred on the needs of whānau and communities. Simultaneously, the pandemic underscored the overbearing complexities with the health system too, and the entrenched barriers to equitable access. The more flexible approach gave us the ability to respond to what an individual or whānau needed, whether it be healthcare or additional social supports, rather than what the system defined or had always done. Throughout, we saw people who were previously disengaged with the health system and often living in remote and underserved communities, engaging with the health and social services. At the same time, this new approach used data and digital services to take significant pressure off frontline clinical staff. For example, some people got advice and help in their own homes, when previously they might have only known to visit a GP clinic or the ED, or to miss out altogether. So the question now is, how can we continue with the momentum built up so far and support new ways of working. This is what the health reforms are all about. Working smarter, building capacity, and ensuring all New Zealanders can get the care they need when and where they need it. I don't want to spend much more time talking about the many inadequacies of the previous system. You know them all intimately. By some measures, it does well. Health outcomes that compare well with other countries, a skilled and dedicated workforce, and an ability to get things done, as we've seen over the past few years. But it has had significant and persistent issues in delivering fairness and consistency. Despite efforts, there were unacceptable inequities, and those would remain if the system didn't change. We need a cohesive and coherent system to achieve their vision of pai ora, healthy futures for all. The system has to put equity at the core, with the principles of Te Tiriti o Waitangi embedded in every aspect. We need a strong healthcare workforce, and we need to shift the focus to keeping people well rather than just treating illness. Primary care, in my view, is one of the best tools we have to improve access and therefore equity and to meet our treaty obligations. Efforts have been made in the past. The primary healthcare strategy from 2001 or 2002 was focused on tackling inequities, and yet we still hadn't given primary care the weight and recognition it deserves. You can do, or we can do better by empowering, collaborating, and being smarter about how we do things. So let me take a moment to talk about the system changes we've introduced. The changes are about the system as a whole and are an important backdrop to future directions in primary care. The change to a single organisation to take over the work of the 20 district health boards was motivated by the need for greater consistency in health services nationwide. It was also about accepting that if we want to do better in workforce planning and recruitment, in clinical innovation, and in harnessing the full benefits of digital and data technology, we need scale, or at least scale in New Zealand terms. The creation of Te Aka Whai Ora, the Māori Health Authority, comes from the realisation that we won't address the serious gaps in health for Māori without leadership by Māori, for Māori, with the ability to commission services directly, to draw on mātauranga Māori and develop relevant health models, and to work in partnership with Te Whatu Ora Health New Zealand to make sure the rest of the health system is making adaptations to better serve the needs of Māori. If we're going to improve health outcomes for Māori and other population groups for whom the health system has been struggling to deliver, other groups such as Pacific peoples, rural communities, disabled people and others, we have to improve access to healthcare. Better access will be the critical factor in improved equity. And that's why what happens in primary and community care is so important. And at the heart of primary and community care is collaboration. The very thing you as participants in this symposium represent. But let me be clear, I don't underestimate the contemporary challenge primary care faces. I know many practices are struggling with staffing gaps and with fears about the future pipeline of GPs. Many roles are full and practices are under pressure with very high patient demand. I think we all know this has been one of the worst flu seasons in many years. And I know the current funding model is a cause for concern, with a capitation formula that no longer takes account of the range of complexities that practices face. But as we reflect on these challenges, we should also see where the future lies. Trying to do more of the same in a world chronically short of health professionals, and at a time when our own medical graduates have ample choices in front of them, is just not going to set us up well for the future. That's why the symposium is so important. For one thing, many of you are already modelling the future with healthcare home. It draws on multiple disciplines, is patient and whānau-centred, and seeks to be proactive rather than purely reactive. The health system changes we've embarked on and the investments we've made in this year's budget should sustain this. The locality planning process, which so far is underway in 9 areas with another 3 not far away, is intended to bring health services in an area together to better coordinate and, dare I say, to collaborate. It's a way to work out the best entry points to healthcare so that communities get the right care right away. It should draw on the strength of all health professionals, including community pharmacy, maternity, aged care, mental health, district nursing, community care, and support, and so on. It should cause a rethink of healthcare models. It should get the best out of everyone. To support the development of the new models, this year's budget allocated more than $100 million over 4 years for tightly integrated primary care teams, with a view to having them in place for roughly half the population by the end of that period. In the meantime, we've allocated $86 million of additional funding to assist primary care for patients with high needs. An additional $10 million has been put aside to boost GP registrar training and a program jointly developed with the College of GPs. And we continue to work on digital systems so they are accessible to health professionals regardless of where they are, so they have the necessary information on the patient they are treating. These changes are consistent with two of the system shifts we've explicitly set out for the new system: reinforcing our obligations under the Treaty of Waitangi and people having more support to stay well in their communities. What I've talked about will take time to achieve. They are, after all, system shifts. But some issues need to be addressed immediately. That's why there is a review underway into the capitation model. Work is also underway to support the training and recruitment of more nurses to fill immediate vacancies. And I'm confident that we will soon make progress on the pay parity issue for practice nurses that is causing a drift of nurses to hospitals or even out of the healthcare workforce altogether. Let me conclude by thanking you for the work that you do each day in this most difficult of times. Thank you for the leadership that you show, but also show by being part of these discussions. I'm confident that your efforts will pave the way for a better tomorrow. Reira, tēnā koutou, tēnā koutou, tēnā tātou katoa.
Tēnā koe, Minister, and tēnā koe whānau. We have got a little bit of time if there's any questions that anyone in the room would like to pose to the Minister this afternoon. Give us a wee wave.
Thank you, Minister. It's Graham Scott. I'm interested in how you see local government participating as partners in the local health networks. There seem to be quite a way to go to get that clear. I'd be interested in your thoughts about how it might unfold.
Yeah, I know that certainly some of the locality work that is being done in those prototype regions at the moment. I mean, I know there is work reaching out to local government. It's certainly my expectation, I've said all along, that when it comes to engagement over health service need in localities, it's not just a conversation of health service providers, but also community representatives and including in that iwi representatives too. As I get around to talk to local government leaders, I say, look, you know, we need elected local government representatives involved in that conversation. They are, after all, people who have won the confidence of their communities, whether it's local mayors or local councillors. I'm not fussed, but we do need that local government voice because that's an expression of community confidence in that engagement, in that discussion.
Kia ora, Minister, ko Ian Toka Ingoa. I am working at PHO in Taitokoro, and there's been a lot of kōrero and whakaaro that's come from the heart today that we've heard. And I think that the intentions of the transformation are meaningful. My concern is that shifting the resources to whānau, to communities, to make the changes to achieve equity are still being stifled through bureaucracy. And I would like to put a call to you and to your colleagues and to Te Whatu Ora, Te Aka Whai Ora, to prioritise that process and see the funding flow. I just wondered if there's anything that you could do to reassure the kaimahi here today that you can support us in that wero. Kia ora.
Yeah, ngā mihi kia koe, Ian. Thank you for that. I hear that, and I think that is a justified concern to have, because I think the reality is we have seen for a long time that kind of when push comes to shove, it is kind of the expensive end of healthcare that ends up being prioritised over primary community care. It is, I've personally said, and I think I can say that on behalf of this government, it is the government intention that we do see a shift of resources to primary and community care. Not just we would like to, we have to see that. And I think the role that Te Whatu Ora can play, must play, is in their decisions. Yes, we have to look after hospital services. Of course we do, they're very important services. But my address was all about the reason why primary community care is so important is that it is the front door for most people in our health services. For a lot of people turning up to ED at the moment, primary community care should be their front door, but they struggle to get access to it. So we do have to see that change. We do have to see better support for primary and community care. I'm confident that we will, and I'm confident that with the values that underpin Priority Healthy Futures legislation, and with the interim New Zealand Health Plan that will be released in the next month or so, and with the work that will follow, we will see that direction setting being very clearly laid out about what will happen with primary community care. So, I will certainly be continuing to make sure in my oversight role that we do see that that shift of resources to that end of the healthcare system.
Kia ora, Minister Little. I'm just asking a little bit more about the how, I guess, with the pay equity and the nursing recruitment, given the international shortage and issues that are facing the health sector and staffing resource, really.
Sure, I made an announcement about some initiatives literally one calendar month ago, 1st of August, but a range of initiatives to beef up our nurse recruitment. We've made those changes to the immigration rules, and I know there's some controversy about, even though nurses are on the green list, they've got a 2-year work to residency, even though, that work to residency is all but a guaranteed pathway to residency. I have to say, in the early applications for that visa, and we've got about 250 odd, I think, visas now granted. A large proportion of them have come from overseas qualified nurses from within New Zealand, for whom the 2-year pathway to residency hasn't been a barrier to their application. But the effort is redoubling within Te Whatu Ora Health New Zealand in terms of recruitment efforts. On pay equity and pay parity, I mean, we have a system for pay equity. We've got one fully concluded pay equity deal that was with admin and clerical staff. We had an agreement in principle with the nurses. That is now the subject of litigation, regrettably. But we are already to go. We have money set aside for pay equity arrangements, and a lot of that intended for the health sector. We've just got to get those deals, and we've got to make them stick. On pay parity, I'd said more recently that I was expecting officials to provide a proposal on how we achieve that, or at least the process for that. Myself and the Minister of Finance got that proposal a few weeks ago. It was totally unacceptable. I won't go into the reasons why, but it had a time frame that was not acceptable to us. And it just didn't seem to take the issue particularly seriously. We knocked it back. I've been assisted by the sector actually to get some data. One of the complaints the officials made was they didn't think they had accurate data. We know there is data there. So we've now got that. So when other ministers and myself are now working on a process which hopefully we can get before relevant parties in a matter of the next couple of months, and get to work on that pathway. So it is one of my priority areas of work. But I've got to make sure that the government officials, who at the end of the ones who release the funds and all the rest of it, are being pointed, in some cases pushed in the right direction.
Well, tēnā koe,
Sorry, I just can't hear that.
Or can you hear now?
No. I'll turn up the volume of the computer I'm on and see if that. Try now.
Kia ora.
Oh,
Can you
yes,
hear?
10 times better, yeah.
So tēnā koe, Minister Little, thank you so much for taking time. And was it Nelson Airport in the back of your van? To spend some time with us on behalf of Collaborative Aotearoa and everyone who's in the room. Tēnei te mihi kia koe. Thank you so much.
Kia ora tātou.